So before we start, I have one disclosure to make. I feel like I need to let you know I've disclosed that I have this irrational fear of snakes. So if anyone brought one today, just leave it in the back with Dr. Keniston, as far away from the podium as you can. I sat down to put this talk together a few days ago, and this is a talk, it's based on a talk I gave in Dubai a couple of times and in Abu Dhabi once on ACL rehab and the particular patient population there. And I thought, how can I spin that into something that's sort of relevant here? And then I look back and realize I've been doing this a really, really long time. And so I have a lot of perspective and a lot of sort of interesting experience over my career. As Dr. Oliver was saying, I'm pretty lucky to have been able to do the things I've done. So I thought I would share with you a little bit of that perspective. I did spend 8, almost 9 years in the United Arab Emirates with Dr. Brown, and we started a visiting medical program there in 1999. And we just went over a few times a year and did a bunch of ACL reconstructions and rehab and trained locals how to take care of their patients. And that led to building a hospital there in 2007 for the government. Up to that point, they were sending all of their ACLs to Europe. So if you tore your ACL, they would send you and your whole family to Europe for 6 months to get it fixed. So it was costing them a fortune. So that program led to building a hospital there. I'll show you a few pictures of that. And then we took a short break, went back in 2014 and built another one. So for a long part of my career, I did almost nothing but knee, sports medicine, and ACL. So I thought I would share some of that with you guys today. One of the things when I kind of look back on this and back in early in my career and how I approach these and how I approach them now, it amazes me that ACL protocols are not standardized, right? You can look at one ACL protocol from one group and look at another one from another group, and there are some glaring differences in them. And it's really based on whoever put it together and what research they happen to be looking at the time. So I try to figure out what are some of the factors that might warrant variations in those ACL rehab protocols. We should probably understand that. And then for me, what really warrants a good ACL protocol? Probably the biggest difference in the way I practice now from the way I practiced the first 10 years out of school was, I can ask anyone in here who's a therapist or deals with the rehab part of this, what would you rather have access to? If you could pick one of these things, so an ACL reconstruction walks into your clinic, Dr. Reitmeyer does an ACL reconstruction, walks into your clinic, you have a choice. You can have Mike Reinhold's ACL rehab protocol. Everybody knows who Mike is. He's a really smart guy. He's a local guy, Northeastern guy. Probably a multi-millionaire now. He's a smart guy. You can have his protocol, or you get 10 minutes with this handsome fellow on the other side to ask him any questions that you want about his patients, right? So I know which one I'm going to take. Early in my career, I would have run right to the filing cabinet for that protocol, because if that patient's 27 and a half days post-op, I need to know exactly what I can do with them at 27 and a half days post-op. But now I think understanding better sort of the physiological healing timeline and functional return timeline now, I want 10 minutes with that guy because I got some questions for him. I'll tell you one of the questions I'm not going to ask him, and that's, what ACL rehab protocol do you want me to use? Because he's a really, really smart guy, right? But he doesn't know which rehab protocol you should use. What he knows is how to put the ligament in there and where to put it and make sure that you don't pull it out. And your job is to make sure you get the function back without ruining his good work, right? So communication is important, but proper communication is what's most important. We'll talk a little bit about that in a minute. So I'm going to go through this part real quick because everybody knows this, right? The ACL anatomy and function. So we know it's a tibiofemoral bridge. We know that it prevents translation and rotation. We know that it's relatively avascular, so it doesn't heal well. That's why we reconstruct them. We don't repair them. We know now that it's 2 bundles. And we know that without it, there's a higher prevalence of osteoarthritis in the knee. We know it's the most commonly injured ligament in the knee, up to 250,000 new ACLs in the US every year, almost 1.5 million female ACL injuries in the last decade, and over 100,000 ACL reconstructions done in the US alone. 100,000 seems like a really big number, right? But I promise you, I got to spend some time in Europe and the Middle East and parts of Asia. There are ACL problems everywhere. It's a bigger epidemic in other parts of the world than it is here. And everybody's doing them. And some people are doing them really well. They do them really well in Europe. They do them really well in Australia. They do them really well in South Africa. So I think it's important. I feel like sometimes, I always think of the US as sort of the epicenter of orthopedics and research and rehabilitation. But it really isn't. There are other people out there doing it just as well, maybe better in some cases. And we should be looking to them for information and for learning too. We know that up to 80% of these injuries are non-contact, isolated ACL injuries, mostly non-contact. We know the mechanism. So we know that you need to have a quad that preloads that ACL. Without it, all kinds of research out that shows that if you don't have a preloaded ACL with a quad, then you can rotate and put it in valgus all you want, and you're not going to tear your ACL. So there has to be a forceful quad contraction, and then you get this sort of dynamic valgus that we all hear about, where the tibia rotates externally and the femur rotates medially, and you wind up with an ACL tear. So the jump stop is where it happens, right? So you get the athlete moving forward at high speed, they decelerate really quickly. There's an enormous quad force at that point, upwards of 6,000 newtons. That preloads your ACL. Then you get the rotational component. And you've all seen film, right? That rotation does not have to be a big rotation. It can be the smallest little rotation of the tibia. If that quad's preloaded, then the ACL goes. So I started thinking back about the history in rehabilitation, and not sure how happy I was that I can speak directly about the rehabilitation of ACLs from 30 years ago. In the 80s, we were doing crazy things with ACLs. We're also doing crazy things like wearing our hair like that guy, and we thought it was cool. So we were doing artificial grafts. We were using Gore-Tex. We were immobilizing these people in casts at 30 degrees of flexion. I can remember my first ACL I ever saw. I'll never forget him. Came from a really good doctor at Mass General in Boston. It was in the early 90s, and he came in a cast just like that, or had just come out of it after 6 weeks, non-weight bearing. His knee was a mess. So we didn't have great outcomes, right? And it wasn't because the knees weren't stable, it's because they were too stable. They were fibrotic and they didn't work. They just weren't functional. Then this guy named Don Shelbourne out in Indiana sort of coined the phrase accelerated rehab. Legend has it that a few of his patients came into his office and had cut their own casts off 4 weeks into their recovery because they couldn't stand it anymore. And ironically, they were walking great and they had good function and good strength, and more ironically, their ligaments were okay. So that was kind of the beginnings of what we think about now as our rehabilitation programs. So we started putting people in braces instead of casts, and we started early mobilization. I think the problem for me is that it led to this sort of wild, wild west approach to rehabilitation. I can remember all this bravado when I worked in Boston. If you, as a therapist, could get your patient back to sports before the therapist next door, you were a better therapist. And almost at the expense of the patient. It didn't really matter because we didn't have all the data to tell us what we were doing was right or wrong. So we were just kind of winging it on our own. But Shelbourne's protocols back then were even crazy, running at 6 weeks, sport activities, cutting and pivoting at 8 weeks post-op, and then full sports at 4 months. So it led to this sort of race to the finish. You know, everybody wanted to get their patients back faster than the next guy, and that made you better at what you did. Fortunately, I think in the late 90s, early 2000s, we sort of came to our senses and the pendulum swung in the other direction. And we said, okay, well, maybe we're not happy with those outcomes either. So with advances in technology so that we could do better research and we could put transducers on ACLs and we could measure forces on that ligament, we were able to come up with better rehab protocols. We began to understand the physiological healing process that occurs in that ligament, everything from tunnel healing to revascularization to regrowth of harvest sites. We developed better fixation and better understanding of our concomitant repairs too. For me, I think my approach has been sort of honed over having this sort of multitude of experience. And again, we are not the epicenter of everything here. There are people doing good work in other places. I got to spend a little time at Ray Moran's place in Dublin, the sports surgery clinic. I did some consulting for them. I did a little consulting for this little soccer club in England called Manchester City. Aspetar is an enormous sports conditioning, psychological center, sports medicine center in Qatar, Doha. They built it to try to get the World Cup. So sort of having all that influence has helped shape me a little bit. If any of you guys like really sappy, good sports stories, picture this guy in the middle is a buddy of mine. His name's Khaldoon Mubarak. And we did his ACL in Abu Dhabi. And we did a revision. He actually had a primary done at a really prestigious hospital in New York. I won't drop any names. And it didn't go well, it failed. So we redid his in Abu Dhabi, and I rehabbed him. He's a great guy. He did a really amazing thing for my daughter. It's a great story. If you want to meet me at the bar later, I'll happy to tell you. After this week, that's where I'm going to end up. So, but anyways, all that sort of influenced kind of the way that I approach things. This is the first hospital that we built in Abu Dhabi. It's called Health Point. It was based on orthopedics and is a multicultural, multidisciplinary center now. This is the second hospital we built. It's called the International Knee and Joint Center. That's the PT rehab center that I got to design. Both of them were really fun projects. They sort of came in and said, okay, build us a PT center and you don't have a budget. Okay, I'm just saying, all right? So it was real, it was a lot of fun. I think the thing that probably helped me to sort of approach things the way I do the most is that I've been really, really lucky in the last 10 years. For a bunch of years, I worked with these three guys on the right, and every morning we would do rounds together in the hospital before we started in clinic. So 6 in the morning, I would meet them at the hospital and we'd do rounds and we'd go room to room. And so it would go something like this. The first room we'd walk in and my friend Fabrizio in the middle would say, okay, this is Mohammed, I did his ACL yesterday, hamstring graft, nice thick graft, I was able to quadruple it. His cartilage is in great shape, I got great fixation, so plug him in, he's good to go. Okay, perfect. So we go to the next room and say, okay, this is Ahmed. I did his ACL yesterday, his hamstring, but his hamstring tendon was pretty short. I couldn't quadruple it, I could only triple it, so I'm not crazy about it. Oh, and I went to put his tibial screw in and the cortical bone wasn't that hard. It was a little bit soft. I couldn't really get it to seat as well as I wanted. So you know what I want to do? I want to delay his weight bearing an additional 2 weeks and keep him in the brace 2 weeks longer. Perfect. Room 3, yep, ACL, hamstring, everything's good. Oh, I did a 2 suture fast fix medial meniscal repair on him. So I'm like, all right, great. Our meniscal protocol is delayed weight bearing 4 weeks. You want to delay him? Nah, that wasn't really a posterior tear, it's more lateral. He can weight bear fully right off the bat. So those things help me to be able to take an ACL protocol that is not standardized and actually standardize it for almost every single patient, individualize it for every single patient that I use. So that level of communication is critical. And I understand that's really hard to get. Again, I'm incredibly lucky to be here at Plymouth Bay Orthopedics because I get that for a second time around. And I don't think many people get that in their career. So all these guys on the left, I get to just run downstairs whenever I have an issue or a problem and ask a question or throw something out there and we get to discuss it and fix it on the spot. I would encourage you with any of our patients from PBOA, if you're rehabbing them, call us, right? Docs are happy to talk. They're all really nice guys and ladies. If you can't reach a doctor, call me, right? I can get you an answer if you need it. So I think that communication is critical because all these things are considerations that you need to take into account when you take the framework of your ACL rehab protocol and you have somebody that's got a different type of graft, an allograft, or you've got somebody that a double bundle. Does that make a difference? Or they've had a meniscal repair or an Oates procedure or a tibial osteotomy. How's that going to impact your rehab protocol? You need to know if that stuff's been done and you need to know if the doctor has any specific recommendations on what he wants to do. It may not fall in line with the protocol that you follow. This is probably the best example of it that I've ever seen. When we got to Abu Dhabi, we found that the rate, there's this phenomenon we call the Arabic knee, and we found that the rate of ACL tear was about 5 times higher than it is here per exposure. And so we started looking at it, trying to figure out why that is. Some of the things that came to mind were that everybody there plays soccer. If you're a male between the ages of 5 and 55, you play soccer. Also, all males in the country at age 19 had to serve 3 years in the military, mandatory. So there was all this male population that was forced into, or participated in high-risk activities. So exposure rates to high-risk activities were probably higher. Also, you saw a patient population that had a tremendous degree of pes planus. So these people walk around in sandals and barefoot all day for generations. So everybody has flat feet, almost everybody. And we know that that pes planus sort of leads to that dynamic valgus that we talk about when you weight bear. The third thing, and maybe the most interesting thing, was when we started looking at radiographs on these guys was their tibial slopes. So you'd see, this is actually an x-ray from one of our patients in clinic, and you can see how that tibia just drops off the back. There's nothing there to hold up the femur. And so as that knee goes into flexion, the femur just rolls off the back and falls off the back of the tibia and just drives the tibia forward. So the load on that, we deduced that the load on that ACL was going to be a lot higher. So that's kind of helped to explain why we were seeing so high rates of tear. But initially, we didn't really translate that into our rehab program and how that would impact our rehab program. I took an ACL hamstring program from the Brigham over with me, and we just plugged everybody into that. Here's a couple of different knees. So these are, again, x-rays from our clinic. So you see the Arabic knee, look at this, that tibial slope is, on average between 12 and 17 degrees, and the Western knee is almost half of that. So that's pretty significant. At the time, there wasn't an awful lot of research out on posterior tibial slope, but there is now. I mean, you can just do a Google search and you can come up with a dozen articles that support it, all in good American, US, and international publications. So we figured it out. So we said, okay, maybe these 3 components are what's the sort of the perfect storm. But again, we weren't really smart enough initially to plug that into to consider that in our rehab program. So we were doing hamstrings on all these guys. No reason to do a patella tendon. They're all pretty small athletes that don't play contact sports. We didn't want them to have harvest site pain. So we did a lot of hamstrings. We know the outcome studies are similar for both. On paper, the graphs look roughly the same. So the patella tendon has a little bit more fixation strength, but the hamstring quadruple is actually a lot stronger. So both of these should warrant a pretty early aggressive rehab program. So we started getting these guys back in 3 months, and we rehabbed most of them, but they would come in and you'd do allotments on them at 3 months, and they'd be 3, 4, 5 millimeters loose. They'd have a good endpoint. They wouldn't be rotationally unstable, but it just wasn't great. Like, we weren't happy with it. And so that's when we kind of went back. And so this communication between myself and Dr. Brown is what allowed us to sort of come to this conclusion that maybe we need to change the whole rehab protocol around. And so we did. We looked at some other things like cyclical loading. So as opposed to sort of a one-time high load, okay, I'll try to finish up within 7%. Instead of a single high load, maybe low load over time was an issue, especially with that tibial slope, and how does that play into that? So we found some research that indicated under 150 Newton load, that graft, a soft tissue to bone fixation graft with an interference screw, if you cycle that thing 1,100 times, you can get graft slippage, not gonna happen, anywhere between 2 and 7 millimeters. At 450 newtons, the 7 out of the 8 grafts they tested failed. None of them failed intrasubstantially. They failed when they pulled past the fixation device. So again, we looked at these essentially failures, with cyclical loading, low load cyclical loading, and then we said, okay, well, how does the tibial slope issue play into that? And it kind of made sense to us that we would get more elongation in these grafts than we wanted if these guys are weight bearing and low flexion angles early. So we made some significant changes in our protocol that you don't see anywhere else around here. Initially it was all the same as you rehab your ACL. So it was manage swelling, get motion back early, extension, extension, extension. You can't preach it enough. Get the quad going, protect the graft. So full passive extension. Here are the big things, right? So we didn't let our guys on a bike until 3 months after surgery. Ellipticals 3 months after surgery, because we didn't want any repetitive cyclical loading in those knees with that high tibial slope. In walking, we put them in a brace for 6 weeks, locked in extension when they walked. So no low flexion angles and weight bearing for the femur to roll off the back of that tibia. And they all had great quads in 2 weeks. They could walk like normal. We were doing hamstring grafts on them, but we kept them locked in extension for 6 weeks. We did all the same stuff that we do aside from that. So straight leg stuff, closed chain stuff. We protected grafts through mid-rehab. We went on to more functional closed kinetic chain strengthening. We didn't let them do stuff that would put stress on their grafts, like leg extensions. So we let them cycle in the clinic in terms of just moving their knee through range of motion, doing closed chain exercises, but their total number of cycles was significantly limited because that's the only time that they did it. Basic proprioception as soon as they were ready for it. And then our protocol was pretty much like everybody else's. So you went on to pre-sport stuff between 3 and 6 months. Remember that with soft tissue to bone, you have tunnel healing at 3 months, not 6 to 8 weeks like you do in a BTB. So we wanted those tunnels healed completely before we let them do any loading, cyclical loading on that fixation. So that was why we picked 3 months for no biking. You start to get some early osseous fibers in the tunnels at about 6 weeks with those soft tissue grafts. So at 6 weeks, we took the brace off and let them walk, but we still didn't let them cycle for hundreds and potentially thousands of revolutions until after 3 months. So that's when we started the cardiovascular stuff, posterior leg strengthening. And then, once you were past 3 months, if they had good stability, most of them had good function at that point, then you were pushing conditioning, strengthening, advanced strengthening, running at 4 months because they were strong by then, basic agility stuff at 5 months. And then we didn't let them back to sports until 9 months, all right? So the research does indicate that there's a slightly higher rate of re-tear and ACL reconstructions with hamstring grafts if you let them back at 6 months, and a little bit less if you hold them off till 9. So we did. So for considerations, for the biggest consideration for you, I think, as a clinician is what's the graft choice? Makes a difference, okay? Understanding tunnel healing makes a difference. So that's the least of what you want to know. Do you get a hamstring, you get a patella tendon, or you get an allograft? And if you're getting an allograft, is it soft tissue to bone or bone to bone? Is it a double bundle? Does that really change anything? Is it a bear repair? Anybody had one of those yet? Anybody know what that is? So bridge enhanced ACL repair, there's second stage of studies at Children's, I think. Look it up, it's really interesting. I've had 2 patients from it. Right now the protocol for that is same standard as a BTB because they're trying to keep everything sort of double blind. So, but you may see that there's some changes in that rehab protocol if things continue to move in a positive direction. Did your patient have a meniscal repair? Right, so that's a big one. And docs will vary on this. Based on the hoop stress of the meniscus, you'd think, well, if you lock them in extension, they should be able to weight bear right away because they're actually compressing the tear together. They're not distracting the tear in full extension. Femoral condyle sits right in the center center of the meniscus in full extension. But some docs still don't want you weight bearing. Maybe you weight bear them in full extension, but not in flexion. So there's a ton of reasons to communicate with your docs on all this stuff. Microfractures, weight bearing and motion and microfractures, and Oates procedures, and then do they have an associated ligament? Obviously that changes things for you dramatically. So for me, I think the take home for what I'd love for you guys to get out of this is what it took me sort of 30 years to learn, and that's it. Rather than sort of following that protocol page to page, be a better clinician. Understand physiological healing timetables. Understand that your healing timeline should go just ahead of your functional return timeline. Your functional return timeline should never get ahead of your healing. That's when you get into trouble. So understanding healing helps you to be able to do that. You don't even need to look at a protocol. Understand tissue loading mechanics. What puts stress on the repaired tissue and what doesn't. That data is out there. And then I think if you just have those two things, you can build a decent, safe protocol. I worked for a really short time back here in the States in between my 2 trips to Abu Dhabi, right? I wanted just a little place close to home so I could be home for dinner every night. And I remember going into interview and the guy says, yeah, you know, we consider ourselves pretty safe here. Like, we're a safe choice for doctors to send their patients. And I remember thinking, well, why don't you just say mediocre? Right? Because that's what safe is. I mean, safe is important, but safe means that you're not really going as far as you can with things. So I think getting your physician input is the third component that allows you to be the best clinician that you can be for your patient. Give them the best protocol and rehabilitation that you can. So again, I think ACL reconstruction is only as good as the rehab the patient gets afterwards, and that's really up to you guys. It's not up to the doctors at that point. So, all right, that's it. Any questions? Thanks for hanging in there. So, thanks very much.